Now going to the diagnosis of meningitis, so we will start with the history and the physical examination. So history and physical examination is the most important thing in the initial diagnosis of meningitis to know which characteristic of patient is more prone for meningitis more than the other in the differential diagnosis, because meningitis is purely a clinical diagnosis, and then you have the investigations to confirm your diagnosis. So in the history and the physical examination, you should ask about close contact, about cat feces, about different infections before, like pneumonia, otitis media, sinusitis, different risk factors that we mentioned before. In the physical examination, you might see Brudzinski, curing signs, and also some characteristic rashes that's related to the, for example, Neisseria meningitidis. And I will show you some pictures to illustrate some signs of the physical examinations. Then coming to the investigation, so first of all, you start with the CBC as an initial lab investigation to check for the high white blood cells like lymphocytes and neutrophils. Then you go for blood cultures and gram staining with PCR to check for bacteremia, PCR for viral meningitis. And also then you can also use imaging. However, imaging is never for diagnosis. Imaging is usually for exclusion of other pathologies. For example, toxoplasmosis on CT is very high yield, that they have ring enhancing lesion, and this is a very high yield information in exams. Herpes simplex virus, when you show or when you have an enhancement in the temporal lobe, especially on MRI, this is really characteristic of herpes simplex virus with the other symptoms of meningitis. And as we said, it has a very similar picture in the presentation of bacterial meningitis. And also we use CT to exclude any space occupying lesion, and this is really important to exclude any space occupying lesion and increased intracranial pressure, because this can cause herniation of the brain and death of the patient if you performed LP or lumbar puncture without checking for that. Another thing that you might do is the rapid antigen testing. So rapid antigen testing can be also used for partially treated bacterial meningitis, and also PCR can be used for that. Another thing is the India ink stain of the CSF to check for specifically cryptococcal infections. And finally, we have the CSF analysis through the lumbar puncture. And this is the gold standard way to confirm your diagnosis of meningitis. We have some contraindications of that. For example, increased intracranial pressure. So if you suspect high intracranial pressure, you do CT before you start in the LP to check if there is any increased intracranial pressure. However, when you do your eye exam and you don't see any signs of increased intracranial pressure, for example, papilledema, there is no vomiting, there is no nausea, then you go with you proceed with the lumbar puncture without checking for the CT. Other contraindications for the lumbar puncture can be usage of anticoagulants and blood thinners that can cause bleeding. Other contraindication also is infection of the overlying skin in the area that you are going to perform the LP on. Now this is a picture showing you Brudzinski sign. So basically Brudzinski sign, when you try to flex the neck of the patient, as you can see in here, the patient will automatically flex the knees, okay? So this is Brudzinski sign, and it's really more sensitive and more specific than the other sign, which is Kering sign. The other sign of meningitis on physical examination, as we said, the Kering sign. So Kering sign is basically when you try to extend one knee, the other knee will flex. This is another sign that you might encounter in physical examination. However, this is very important that you should identify it. So the meningococcal rash is very important. That means that the patient went into meningococcemia. That means bacteremia and disseminated infection of Neisseria meningitidis. So the characteristic rash usually present as purpura that does not blanch when you press on it. It can go into petechiae. That means it's progressing, and this is very serious. And then after that, it can progress into ecchymotic necrotic areas. And fortunately, this rash responds very rapidly to antibiotic. But the most important thing that you have to recognize this rash. This is a CT showing the ring-enhancing lesion in Toxoplasma gondii. So this is a high-yield information showing here the Toxoplasma gondii, as they might present as the same symptoms of meningitis, or fever, headache, and decreased level of consciousness and neck stiffness. So you have to identify it on CT. Another picture showing you the gram staining of a CSF or blood doesn't matter. However, the gram staining shows you here the gram negative, so it's red or pink. So gram negative diplococci. So when you see that on the primary report, you always suspect Neisseria meningitis, and as we said, you have to start treatment as soon as possible. Now going to the different CSF findings and different types of meningitis in here. So as we said, the gold standard is the CSF analysis from lumbar puncture. So according to the type of meningitis, you confirm your diagnosis as bacterial, viral, or TB meningitis as part of the chronic meningitis. So let's start with the bacterial meningitis. So bacterial meningitis, the CSF color is going to be turbid. Turbid means that it's going to be milky, and this is because of the pus secretion of the organisms, and pus secretion, this is because of the neutrophils is defending or trying to defend the CNS. So the most important white blood cells in the bacterial meningitis is going to be raised, the neutrophils. So neutrophils is going to be raised. Another thing in here, that the protein is going to be raised in most of the types of bacterial meningitis because of the vasodilation and increased vascular permeability. That's why you will have leakage of the proteins, specifically in the bacterial and TB meningitis. Finally, we have the glucose. So bacteria usually use glucose as a source of energy. That's why it's decreased in the bacterial and TB meningitis. Viral, it's not that much of a decreased glucose, and sometimes it can be in the normal ranges. So coming back to the viral meningitis, the CSF fluid is going to be clear, and the type of white blood cells is going to be a lymphocyte, so increased lymphocytes in the CSF. Protein might be increased or normal. As we said, it might have some sort of vascular permeability with that, and the glucose is most likely going to be normal. Now going to the TB meningitis. TB meningitis can, the color of the CSF can have anything turbid or clear or viscous, and you will have mostly increased lymphocyte, although it's a bacteria. However, lymphocytes is the one going to defend in this case. And as we said, because of the vascular permeability, you will have increased protein, and because it's a bacteria, it will use the glucose. This is a picture just to show you the difference between the normal. So we have here the normal CSF fluid, and you have here the milky or the turbid CSF fluid that you see with bacterial meningitis. Now going to the management of meningitis. So management of meningitis can be classified into the general management or general status of the patient, and then specifically toward the meningitis itself, if it's bacterial, fungal, viral, or TB meningitis. So let's first start with the general status of the patient. So first of all, because of the increased intracranial pressure, you will try to decrease that intracranial pressure, so you'll give mannitol. And sometimes you give also steroids in the first 4 days to decrease the edema and intracranial pressure. Close monitoring of fluids and electrolytes and glucose, and specifically the acid-base disturbances is very important in the management of the patient. Now going to the specific management of different types of meningitis, we will start with the bacterial. So bacterial in general is going to be antibiotics, and we will illustrate that and talk about it in details in the upcoming slide. Then we'll go to the viral. Viral is usually supportive when you have intraviruses causing the meningitis. If the cause of meningitis is HSV or herpes, the treatment is going to be acyclovir, and this is a very high yield information. TB is going to be anti-tuberculosis therapy, and fungal is going to be the antifungal drugs. Now going to specific management of bacterial meningitis, which is antibiotics. So a very important thing that you should know, that antibiotics should start as soon as possible, even before identifying the organisms and before the culture results. So you start empirical enough to cover the suspected organism according to the age group that you have. Okay. Another thing you should know, that you can give the antibiotic intraosseous if the patient is in shock and you can't have an IV access. And if you can't have an IV access, however, the patient is not in shock, you can give it as an intramuscular injection. Now going to the empirical treatment of bacterial meningitis. So let's say here that we have a summary to this table. So you start with a third generation cephalosporin. So, for example, you can start with a ceftriaxone or cefuroxime, or cefotaxime, sorry. Another thing, you should add vancomycin if you suspect, so you can add vancomycin if you suspect strep pneumonia. You can add also ampicillin if you suspect the presence or the infection of Listeria monocytogenes, okay? So this is the general rule for empirical antibiotic. Going back to the table, so this table is showing you the empirical antibiotic according to the age group. So let's start to see here the 3-month-old, for example, the neonates and infant. So what organism do you suspect? We suspect usually the Bell organisms, which can cause sepsis, the group B streptococcal infection, the E. coli, the Listeria monocytogenes. So you start with the ceftriaxone or cefotaxime, our general rule, and ampicillin to cover the Listeria monocytogenes, okay? What to use ceftriaxone or cefotaxime? Well, if the patient is less or equal to 1 month old, okay, you try to go away from the ceftriaxone because ceftriaxone can cause biliary sludge, and through that it can cause biliary obstruction. That's why you avoid ceftriaxone in patients less than 1 month. Going to the next age group, 3 months to 50 years old, which is infants and children and young adults. All of these, they have the same organisms approximately, like the Neisseria meningitidis, Haemophilus influenza, and the strep pneumoniae as the most common cause. So you cover this with the 3rd generation cephalosporin, and to cover the resistant strain of strep pneumoniae, you add the vancomycin. So this is the general rule. And then going to the final age group, we have the elderly patient who are susceptible for Listeria monocytogenes. So the same therapy in here because they are also prone to strep pneumonia. So you cover it for the resistant strains with the Vanco, and you add ampicillin for the Listeria. Now, after getting the culture results and the sensitivities, now you try to adjust your management plan. So according to the organism, you adjust your antibiotic management. So for example, Neisseria meningitidis, you give a booster of penicillin G with the 3rd generation cephalosporin. The strep pneumoniae, to cover the resistant strain, so you add vancomycin to the 3rd generation cephalosporin. H. influenza, you only use the 3rd generation cephalosporin, either cefotaxime or ceftriaxone. And finally, we said for the Listeria, we cover it with the ampicillin. And according to the organism, you have the duration of the treatment. Now, finally, reaching to the complications of meningitis. Let's start with the most common one, which is hearing loss, which is the most common long-term complication in children. What organisms can mostly cause hearing loss more than the others? So let's start with the most virulent one, which is the strep pneumoniae, causing most of the hearing loss cases in meningitis. And then Neisseria meningitidis in the next level. And finally, we have the Haemophilus influenza type B, causing the least cases of hearing loss as a complication of meningitis because of the vaccines nowadays. Another complication that may result from meningitis is cerebral abscess that can result from partially treated bacterial meningitis. And then we have hydrocephalus because meningitis can cause scarring in the subarachnoid space, therefore decreasing the absorption of the CSF fluid, thus causing the communicating type of hydrocephalus. So communicating type, okay? Another complication, as we said, it's part of the symptoms also, so increased intracranial pressure. So one of the complications, as we said, the ptosis and the photophobia that result from dysfunction of the 3rd cranial nerve. Finally, we have the focal seizures and epilepsy that may result as a complication. And when you have a focal seizure, they usually result because of the HSV meningitis. So this is usually with the HSV meningitis, and they usually present with an opacity or high intensity, high opacification, in the MRI. So when you have a patient with focal seizure and symptoms of meningitis, and MRI is showing an enhancement in the temporal lobe, this is usually all directing into herpes simplex virus meningitis. Now coming to our final part of this lecture, which is the prophylaxis or immunization. So we have the chemoprophylaxis, which is following the exposure for people who are in close contact with meningitis patient, for example, the family and the nursery kids and those type of populations. So you usually give rifampin as a chemoprophylaxis, especially for Neisseria meningitidis and Haemophilus influenza meningitis. You also have the immunoprophylaxis, which is really important, specifically in the immunocompromised patients and sickle cell anemia patients and thalassemia patients who have asplenia or splenectomy. So they usually have a booster of immunizations or immunoprophylaxis for encapsulated organisms. So they usually have vaccination for Haemophilus influenza, PCV for the pneumococcal meningitis, and the polyvalent meningococcal vaccine. Coming to the end of our lecture today, these are our references, and thank you for listening.